So we have a 60-year-old lady, hypertension, no diabetes, presented with unstable angina. And the ECG actually showed transient ST elevation and settled quickly. So every reason to believe that this was a true unstable angina could be hard in view of the ST elevation. This is the angiogram, and you can see we have a critical disease at the ostium of the LAD. There is a big ramus or OM1 coming up, and a circumflex which is very large and dominant. And one could possibly feel that there is some disease at the origin of the circumflex. So we have a kind of a triple lesion. I have a frozen frame for you. Shows LAD significant, and this was the culprit artery because we had ST elevations in the anterior leads. We have ramus, which is showing a significant disease, and what I'm talking about is some disease at the beginning of the circumflex. I think a couple of things are important. I felt that the ramus was a reasonable sized vessel, and I certainly don't want to lose it during the procedure. Acute loss of this kind of vessel during procedure is a disaster. So I would like to do something for left main for sure, for the ramus for sure. As you saw, this is the anatomy, and oh, it's not getting connected, excuse me. You need to connect. So to me, this ramus is not a pushover. To me, there is some disease at the beginning of the circumflex, and the angle between LAD and the circumflex is very narrow. It's almost like they're running parallel. So possibility of T-stenting is almost not there in this case. So we have studies like left main compare, syntax, and all that we are talking is benefit of CABG over PCI is limited to fewer repeat revascularization. Otherwise, the two procedures look pretty similar. And thus, it takes us to a point that have we finally come to a conclusion that the PCI of unprotected left main coronary artery is better option than CABG. We're almost at this level. And this is how the things have moved in 2010 as far as the ESC guidelines are concerned for left main stenting. When we talk of left main, we are basically talking of almost always of bifurcation. Almost 65% or more cases are actually at the bifurcations. So we are very rarely talking of only orchial or only shaft kind of lesions. So overall, we have 80% lesions which are actually touching the bifurcation. Coming back to our case, this is another similar case which we are trying to show you. Mind you, the ramus coming out of this artery is a huge vessel going all the way. And the lesion is actually at the ramus origin and a moderate lesion at the origin of the LAD. So this case, actually, I was the LAD, and that lesion was important. And we thought we should have this kind of strategy. So a stent from left main into ramus, which was actually a bigger vessel than LAD, and then a stent from this point onward into LAD, ending up with this kind of lesion. This was the final result, and this is a check angiogram. Sorry, this is how it is in stills, that one stent is going like this and second stent here. And this is a check angiogram at the end of 2 months showing that everything is functioning very well. So this has been our strategy more or less in left main stenting, that we should be addressing whatever lesions are seen on the other side. So moving to our case, and I want you people to remember these images, and that's why I got it on stills. This is the culprit artery, very tight lesion, ST elevations transient coming from here. This is an important narrowing, and I certainly don't want to lose it, though I want to end up with 2 stents. So we switched from a 2-stent strategy, which was quite obvious in this case, to a 3-stent strategy. And this is how we are doing it. We have 3 wires in the 3 vessels. We come in with the first stent from left main into circumflex. This is the biggest diameter vessel it's a dominant circ. And I thought putting a stent from left main to circumflex was very important. Once having done that, we have this kind of image. We still have a significant narrowing at the other vessels. We pull back the wire, which were substrate, get into the lumen of the vessels. And these are the kind of images that you're seeing. The main stent is looking pretty good. So we now look at the ramus. And ramus is an important vessel. So we come in with another stent in the ramus, starting from here, a balloon placed in the left main to circumflex. We inflate both simultaneously almost, and we deploy the stent in ramus. And then we bring another stent going into LAD and put a balloon which was actually going from left main to ramus while deploying the stent in the LAD. So it's a kind of LAD stent getting deployed right at the osseum with a protection to the left main to circumflex. And this is how we go on. And this is how we get images. So our first stent is left main to circumflex, second from osseum going here, third from osseum going here. So we now see some kind of deficit at the origin of the second stent, which was going into ramus. So we come back with a KISS at that point. We use non-compliant balloons, obviously, and high-pressure inflation. And this is the end pictures that we are getting. So we have, in fact, instead of 2 stents that we discussed, we actually have 3 stents placed in. And to me, ramus was an important vessel. So this is how we started, and this is how we ended. So obviously there is going to be a lot of discussion whether it should have been 2, 3, 1, and whatever. But I think we have various options, and I'm sure all of us address these kind of issues very differently. Thank you indeed for your attention.